Guys, so skin and soft tissue infections, you guys have been hearing about these from med school. So we've mixed in some questions along with some key learning points. My lecture is based on the ID board review lecture on skin and soft tissue infections and this. It used to be the purple book, but now the new version is the green book. If you guys haven't seen it before, I brought it in so you guys can see it. There's a book, comprehensive review of ID. It's more written in like bullet point format than like Mandel's. It's a little more less overwhelming. And then they also have a companion like question guide, and that's where the questions all come from. Yeah, take a look.
Okay.
Yeah. And then I just brought them in if anyone wants to see what they look like in person. I'll probably leave the question book in the ID office at TGH because I have the online access code. Skin soft tissue infections. Some key points are they're very common. You guys know this, right? We had about a dozen this weekend on call at Tampa General of varying flavors. Most commonly, they're caused by gram-positive bacteria, staph, and strep, by far the most common. And another sort of point that often comes up with skin soft tissue infections is treatment duration. Often they should really be based on clinical response. You know, usually you either see 5, 7, 10, 14 days, some, you know, those multiples of 5 or 7. But in general, most of the time, ideally, patients would be treated, you know, until they're better and not just an automatic course of 7 to 14 days the first time they come in the emergency room or whatever. There are IDSA guidelines for skin and soft tissue infections. They are over a decade old, so, you know, these skin and soft tissue infections aren't that different, but there may be some things that have updated. We're going to go through all the different types of skin and soft tissue infections, but this, I feel like this figure, I just want to make sure you all have seen before from the guidelines because it sort of defines how we treat a lot of these. And the big differential here is when you're thinking about a skin soft tissue infection is it purulent or non-purulent? And that sort of guides which bugs you're covering. And so when it's purulent, what are we want to make sure we cover? Yeah, staph aureus, and specifically usually MRSA when it's purulent. When you have a non-purulent infection, often you can avoid that. So, and again, we'll break it down more, but this figure is nice. So skin and soft tissue infections, we see different clinical ones. You know, we define them by how they appear clinically, but they're based on how deep they go in the different levels of the skin. So this graphic shows the layers of the skin, and then along the side, you can see that like impetigo, folliculitis, erysipelas are in the more superficial layers, ecthyma, abscesses are in the deeper layers, and then neck fascia is deeper. You could also add on there like pyomyositis is deep into the muscle layer. Things that put people at risk for all sorts of skin and soft tissue infections. Obviously, something that allows the skin barrier to be disrupted, so trauma to the skin of any sort. And then other things, immune deficiency, disrupted drainage, vascular insufficiency, inflammation, foreign body, obesity, or poor hygiene is listed as a risk factor. Okay, so now I'll stop talking so much. We'll do some questions. Can you read this one?
A 7-year-old boy is brought to clinic with several small pustules on his face that have ruptured, leaving honey-colored crusted lesions around his mouth and nose. He is afebrile and otherwise well. His younger sister recently had a similar rash. Which of the following is the most likely diagnosis? Impetigo.
Yeah, these questions are not all the most challenging, but that's okay. So impetigo, and we'll talk more about that in a second. So can you guys name these different infections?
Yeah. Is it purple?
Nope.
The top right one, is that like?
It does have that butterfly distribution.
Yeah.
That could be a lot.
In the category of skin soft tissue infection, And related to that one, no, don't go. We're not going for it. This lecture cannot cover everything that like causes a rash or skin finding. Good, we stumped you on one of them. Do you guys know? So what's that one? Impetigo. Is there another variation of impetigo you've ever heard of that may cause something like bullae? There you go. Okay, so we'll go through each of these. This was just sort of to get us thinking. But you guys got it. Impetigo, ecthyma, erysipelas, and then bullous impetigo.
Yeah.
Yeah. So impetigo, you guys like clued in right away, right? The honey colored crust, you guys know. It's mostly common in kids, and it's especially like around the nose and mouth area. Sometimes kids can have like some sort of rash from a viral infection or a minor trauma. And then you start to see this develop. It's more common in hot, humid climates and hot, humid weather. It's usually strep and or staph. Most of the time, if it's sort of localized, you can just use topical like ointment, the mupirocin. If it's severe, like very spread out, then people may get oral antibiotics. This can be complicated by post-strep glomerulonephritis. So if they were to give you a board question describing this and then asking about, signs of that down the road, there is that association. And then bullous impetigo. 10% of cases of impetigo, and you develop these flaccid bullae that rupture, and then you get crusted lesions, and it's due to a toxin-producing Staph aureus. So you can see on the top one, like you can sort of see one of the bullae more on the side of their neck, and then you can see where they've, like the bullae have ruptured, and they look like that. So you can have multiple lesions. It's still more common in kids, I would say, though obviously that top picture doesn't really look like a child. But you can get it in adults. Ecthyma, you guys correctly identified from that initial picture. It's sort of like these more punched out looking lesions. The top two in particular look at. And it's in the epidermis to superficial dermis. They crust, common on the lower extremities, and you treat it the same as you would impetigo. It's usually strep cause. Just because when we hear ecthyma, we often think of ecthyma gangrenosum, which is, there's ecthyma and then there's ecthyma gangrenosum. And ecthyma gangrenosum is what we'll see at like Moffitt or in our really immunocompromised patients who have bacteremia, perivascular invasion. It's classically due to Pseudomonas, but can be due to many other things. So that bottom picture is ecthyma gangrenosum. Wanted to include that since I know you guys associate it. And then erysipelas, another one you guys correctly identified. So erysipelas is that raised, it's well demarcated. You can sort of draw a line around it easily. It's very red. It can be indurated. The butterfly distribution on the face is typical, or you can also see it on the lower extremities as like a well-defined patch. People can have fevers, chills. It comes on quickly. It's due to strep generally. And if it's mild, you give them an oral antibiotic for this. If it's more severe, you do IV, and that's sort of true for most of these infections. Moving on to a different category, so folliculitis, infection of the hair follicle, right? So you can see sometimes it looks a little bit like pustules on the top. Sometimes it's just more red, and it occurs in parts of the body where you have hair follicles, right? Like that's where it tends to be. Generally caused by Staph aureus. If it's mild, you can use topical if you want. It's usually self-limited, but if someone has severe distribution, you can treat with systemic antibiotics. Okay, so another question. Can you read it for us?
A 42-year-old male presented to his primary care physician with 4 days of mildly pruritic rash, predominantly around his groin and his legs. He was otherwise feeling well. On exam, he was noted to have multiple punctate areas of erythema surrounding hair follicles in his groin and on both his legs. He had no palmoplantar lesions. He also mentioned that he had spent several hours in his hot tub the week before he noticed the rash. What is the most likely cause of his folliculitis? Oh, possibly could be deep pseudomonas.
And why do you say that?
I think there is association between pseudomonas and hot top folliculitis.
Anyone have other thoughts? Which mycobacterium do you usually see associated with water exposure? Marinum? That's marine in it. Yeah. We'll get to aquatic exposures, but yeah, that's sort of the onset of this 4 days, this pretty, the rash in the areas that are covered by the swim trunk is pretty typical for hot tub folliculitis caused by Pseudomonas. It usually starts pretty quickly, 8 to 48 hours after exposure to the contaminated water. Funny enough, I just got a hot tub this summer with my new pool, and so I think about this every once in a while. It's usually self-limited. The answer to this question said you don't usually use systemic antibiotics. Sometimes people will treat with ciprofloxacin if it's diffuse. And here's that top picture is a picture of hot tub folliculitis. This is from ID Board Review. You can see the distribution of folliculitis is like under the bathing suit where that contaminated water was sort of sitting for a bit. And they say to treat with ciprofloxacin. You can also get other types of folliculitis. So we talked about the most common one being staph. That's the typical folliculitis you see. You can also get fungal in people who are, at risk for fungal infection. So, compromised. You've gotten steroids. You've gotten a lot of broad spectrum antibiotics. Eosinophilic folliculitis, I just added in here because it's another folliculitis we see in people with AIDS. It's usually on like sort of the trunk, upper chest. And then another one is avian schistosome cercarial dermatitis or swimmer's itch. That's what the bottom picture is of. And this is, have you guys heard of this one? Swimmer's itch. So it's after people go in freshwaters and freshwater that has a lot of snails. And so you get this molluscan host release these cercaria. They trigger an allergic reaction in the hair follicles, which is sort of cool. It doesn't need antibiotics, but it's very, very itchy. More common in kids who play in like the shallow water where those snails are living. Okay, Shrina?
A 22-year-old male presents with a painful swelling on his thigh. He denied any associated fevers or chills. Patient applied warm compresses to the site for the past 2 days with little improvement. He was normally well, did not take any regular medications. On examination, there was a 3 centimeter lesion on the inner thigh. The lesion was warm, tender, fluctuant palpation. The rest of his physical examination is unremarkable. Which of the following is the most appropriate treatment? A hold antibiotics.
You don't have to read them all out.
Okay.
You can just read them.
Used to doing that.
It's fine. Any thoughts? See? You guys are going to do that?
Oh, yeah. I'm a target for procedure.
Oh, yeah. And what do you call this? What is this? Abscess. Yeah, where you want to drain it.
Oh.
Carbuncle and furuncle. I feel like we don't commonly use those words. We just say an abscess. But we'll define what those are. And you're right. At 3 centimeters, like more than 2, you generally want to try to drain that. Antibiotics alone are not as effective. You don't need to take him to the OR. This is a stable guy. And you would never get a superficial wound culture for something like this that's deep in the skin. So furuncles and carbuncles, these are abscesses in the dermis or subcutaneous tissue. So we're getting deeper in the skin layer. Again, they usually occur on more hairy surfaces. Furuncle, some people will call it like a boil. And that's like a deep infection of the hair follicle. And then if multiple of those furuncles coalesce, you end up with a carbuncle. Usually Staph aureus, though, like anything, other things can also cause infection, especially if you get in like the genital region, then you can have more gram-negative rods or anaerobes. For a furuncle, so just that boil, usually they're not as big, may not need IND, antibiotics may be fine. Carbuncles, like the one in this picture, are going to need an IND plus antibiotics to really get better. And obviously, when you have an abscess, it's carbuncle, if you leave it untreated, it can develop into bacteremias, more complicated things. And then there is an association that board review mentioned that if you have a carbuncle in the face area, it can, if it goes deep, can cause a cavernous sinus thrombosis. So one of those associations to be aware. Yeah.
I just want about NTM in freshwater. I think that's really in Florida, which is southeast of Berlin, that they have these old mines, and the mines are freshwater, but they're not clean. So to your point of the Mycobacterium in spas or freshwater, you see that in real life with people swimming in swimming pools that aren't really swimming pools, they're old mines. So we had one with total and I think it was a mixture of Mycobacterium in our leg. So just please think about that. Also for boards, Pseudomonas is not only in your spas, but also on nails in the environment. So when you have someone with scrapes, right, you want to think about Pseudomonas also. Doesn't seem like it, but that's a classic board question if someone gets a nail through their sneaker and it's actually Pseudomonas. So that was on the boards. Another thing, I'm sorry, AIDS folliculitis, really important. That's when someone's viral load is not controlled, or if they first present. I had a patient who actually would get that every time he was off his ERT. And what you do, you have to treat it certainly almost with an antifungal, like a ketoconazole, because you have tinea that gets into that folliculitis. So you treat it not only with ART, but sometimes you use an antifungal to help that. Anyway, so just wanted to throw that out there. And then you do the, oh my gosh, like the anti-dandruff shampoo, believe it or not, on the brows and the beard. So I just want to put that in there because that comes up on the boards in real life. So thank you.
Yeah, I took out the question just for time, but I did have one about nail or any sort of penetrating trauma through the sole of a shoe is Pseudomonas on the boards generally. Yeah. So the one we see very commonly, cellulitis, right? Are you guys comfortable distinguishing cellulitis from erysipelas? What's the difference, or how would you tell clinically?
Erysipelas is demarcated.
Yeah, that's a big one. So, and this picture sort of shows you with cellulitis, we often draw a circle around the general border, but usually that's sort of like, if you change the lighting, your border might be slightly different. The erythema is not super well defined at the edges, but with erysipelas, you usually can draw a pretty clear border around it. So just distinguishing those. I think you guys know the clinical features of cellulitis, of erythema, edema, warmth, fever, chills. Most commonly affects lower extremities, but we all know cellulitis can occur anywhere on the body, particularly in areas where you've had a trauma, a surgery, something happened that, again, disrupted the natural skin. Staphs and streps are by far the most common. And then depending on where on the body it is, you can have all sorts of complications.
So 72-year-old female presented with 4-day history of worsening pain in some leg of her right arm. She had a history of hypertension, AFib, diabetic diabetes. She's had a radical mastectomy, chemotherapy for invasive breast cancer 5 years prior, with an associated DVT of her right leg, and was currently undergoing investigation for unexplained iron deficient anemia. The left arm shows significant edema. Skin appears erythematous or purple tinged. The swelling appears tense and involves the entire arm from the hand to the shoulder. What risk factors most likely be responsible for recurrent infection? Yeah.
Have you guys seen this before?
Yeah.
Okay. Yeah. What about those other things? Are they risk factors too?
And the edema chronically, I thought that she may have developed another DVT of the upper extremity.
Yeah, you probably want to evaluate for that, right? In the real clinical setting. Agree. Yeah, and you guys got the exact thing. This isn't something that we definitely see lymphedema post-surgery, and then risk of developing cellulitis there. And so when people are having recurrent cellulitis, once people have one episode of cellulitis, they're more prone to additional episodes in the same location. The lymphatic system can be affected. But there's some risk factors. So I'll skip to the second bullet point first, the upper extremity, like we just discussed, often it's like a post-mastectomy or node dissection, surgical disruption of that lymphatic drainage. In the lower extremities, it can be the same thing, but, surgeries in that area. So pelvic surgeries, radiation, and lymphedema of any cause. These recurrent cellulitis, it's most commonly due to strep species, usually not group A strep. And the management, you sort of want to, if people are coming in with recurrent episodes of cellulitis from lymphedema, you sort of need a multi-pronged approach here. So non-pharmaceutical interventions, especially compression. There's a lot of studies on compression for people, and that can reduce recurrent cellulitis episodes, as well as things like, elevation, treat whatever the causes of lymphedema if you can. And then in people who keep having recurrent episodes, sometimes we'll consider antibiotic prophylaxis, often with the penicillin. Okay.
I read the question first. What agent would be most appropriate to add to penicillin to control this? We have a 57-year-old man presenting with left lower extremity pain and swelling at the site of minor trauma sustained 5 days prior. He's bipolar and has alcohol misuse disorder, no allergies. On exam, there's induration and erythema, and he has a temperature of 38.5, which is Fahrenheit. It's like 101.5, and white blood cell count of 18,000. Broad spectrum antimicrobial is starting narrow. He's taken an OR where neck fash and purulence were noted in distal extremity. Cultures of multiple intraoperative specimens were positive for strep pyogenes. Antibiotic therapy was changed to penicillin. So what would you add? For pathogenicity, I would add clindamycin.
Everyone agree? Good. I'm glad this was not challenging for you guys. So clindamycin interrupts protein synthesis and toxin production. More and more people are using linezolid over clinda these days, but as an alternative. And for strep pyogenes neck fash, you should be using that antitoxin agent until you have source control. Another one before we more formally talk about neck fash.
Acknowledged using injected drugs. On exam, there's minimal erythema in the left antecubital fossa, upper arm with significant pain on palpation. Mass is seen on the fascial plane, suspicious of neck fash. In addition to emergent surgical debridement, what would be the most appropriate antibiotic regimen?
Big guns on this one, probably be.
The IV drug use, like that change and
Yeah, how's this different from the last case where you guys were doing penicillin and clinda? Okay.
Clear. Okay.
So E, you guys are going broad? Yeah, definitely one broad here. And so necrotizing soft tissue infection. Remember that when we showed that initial figure of the layers of the skin, this is deeper in the skin. And so the skin may be spared initially. That's why we always talk about people have pain out of proportion to what we can see on our physical exam. But it rapidly progresses. So if someone's reporting that pain out of proportion, you definitely want to, have that flag come up in your mind and then monitor closely because it will rapidly progress. Crepitus, discoloration, blisters, bullae, necrosis. They'll get septic, shocky. Most commonly on the extremities, but can happen at different areas. Fournier's gangrene is one we see a lot when it involves the perineum. Labs, there's the Larinic score you can look at that can give an idea, but this is really a clinical diagnosis. So labs, imaging can help support, but you usually aren't wanting to wait on getting imaging. We had one yesterday where the consult was concerned for necrotizing infection. So we first reached out to them and said, can you consult surgery, before you wait? Yes, I will adjust antibiotics, but can you please consult surgery now? Yeah, so that was 8 a.m. yesterday. So, and as we've gotten out with these past two board questions, there's sort of two different types. So the first case we did was type 2, monomicrobial, often group A strep, or Staph aureus, Ehrlichiosis, Vibrio. We'll talk about those in a minute. And so in those, you can target the bug of. With strep, you can target it with penicillin. Type 1 is the mixed necrotizing infection, and that's what you were targeting in the second case to cover all of these bugs. So you want gram-negative, gram-positive, and anaerobic coverage there. IV drug use, you have the also association potentially with Clostridial infection. Management, and you guys know for neck fash, surgery is key. Antibiotics, we will do our best, but it's rapidly progressive and needs source control. mortality can be very high if not treated. Heal with steel. Oh, interesting. Okay. And then one more that maybe doesn't count as a skin and soft tissue, but often associated with these is pyomyositis. So this is infection of the skeletal muscles. We had our guy who had this in his remember underneath his groin, he had that it was erythematous in his groin and it wasn't getting better despite appropriate antibiotics. He had MSSA bacteremia. So repeat imaging finally showed that there was an abscess, pyomyositis, and he needed source control. But in his case, it looked like a cellulitis, it was on the skin, but it wasn't getting better in the time we would expect. So we looked deeper. Staph aureus is the most common cause of pyomyositis, and you generally need drainage plus antibiotics. If it's in areas of the body at risk, you can develop a compartment syndrome from the swelling associated with it. And I referred to this on that prior slide, but Clostridial myonecrosis, also known as gas gangrene, is rapidly progressive infection due to Clostridia. And again, it's like necrotizing fash, and you have the pain out of proportion to your physical findings. The things it's associated with and where questions will come up is like a septic abortion can put you at risk of this anaerobe infection, penetrating wounds or surgical wounds involving the GI area. And then injection drug use and skin popping with that black tar heroin as well have been associated. And you treat this as we treat the other neck fash with emergent surgical debridement. Okay, these are sort of some fun association questions. Male
presented 2 days of water diarrhea, a day of large fluid-filled skin lesion. He has a history of cirrhotic liver disease. He had recently returned from a fishing trip on the U.S. Gulf Coast. He had been swimming in the hotel pool but not the sea. By examination, he was dehydrated. His symptoms 38.3 degrees Celsius. His blood pressure was 88/52. His heart rate was 115. Investigations, blood culture is curved, gram-negative rods seen on the microscopy.
Okay, what do you guys think he has? And what are the clues in the question that are pointing there?
Cirrhotic liver disease, a fishing trip.
Yeah, they sort of gave you all the keywords here, right? Yeah, so Vibrio infection. And he got it, I think they are trying to say he didn't swim in the ocean though, because we think of it as exposure, but it can be water exposure or the ingestion of contaminated seafood. And people with liver disease are the ones who tend to get very sick for this. And what's the treatment for Vibrio? You may need to.
Doxy plus ceftriaxone.
Yeah, so you want to make sure you have that doxy and ceftriaxone. Yeah, it's not our typical antibiotic coverage is not quite appropriate. So if you can't tell, this is water exposure infection questions. Who's up? Taylor?
What is the most likely cause of his infection? Mania, Mycobacterium, nocardia, Vibrio, possibilities. It's a 55-year-old male who presented with a 3-month history of progressive erythematous nodules on his hand and forearm. He fishes frequently and remembers puncturing his finger with a fish hook about 2 months ago. The puncture wound healed initially, then he developed an erythematous nodule at the puncture site. He later noticed 2 new nodules on the dorsum of his hand proximal to the initial injury. He now has another new nodule that just developed on his forearm. What's the most likely cause of this infection?
Yeah. What about those other ones?
His exposure, it's not fishing.
Yeah.
The other 2, it's I did it 2 months ago.
Yeah. I have to say, I got this question straight from that book, but the 3 months and then 2 months is confusing me because it's not quite right, but just pretend it makes sense.
Oh, yeah.
Oh, yeah, that's
Yeah. And what do you call that spread of the lesions going up the arm? So nodular lymphangitis or sporotrichoid spread. And at the end of this lecture, I have a slide with some of the different causes because boards do seem to love that too. So Mycobacterium marinum, fresh and salt water, swimming pools, fish tanks. It can be someone who works at an aquarium. We had someone who worked at the aquarium recently with a weird infection and considered things. So some of the aquatic exposures and related skin and soft tissue infections, Vibrio is of course a big one, and it's been in the news this summer. It comes in the news every summer with warm waters. We tend to see more of it. And we talked about how it presents, Mycobacterium marinum. The treatment we haven't talked about for that, so it's multiple antibiotics for months. Usually you'll try to get susceptibility testing. And then Aeromonas is one we hadn't talked about yet. It's in freshwater and brackish water. It can also cause necrotizing soft tissue infections as well as, more mild cellulitis. And medicinal leeches can be associated with Aeromonas. So if they're using medicinal leeches, often you'll prophylax for that. And they do sometimes use that. This is a case of Vibrio with sort of rapid progression. It's swollen. You can start seeing things. And then those like blisters are very typical for Vibrio. And then this one is Mycobacterium marinum, where you can see those nodules moving up the arm.
We had a lot of Vibrio.
Yes, we did. Yeah, hopefully not.
Last year we saw that.
Yeah, we did a couple.
There was one of the VA well before the hurricanes went really bad in February with HIV. We had that.
He was the guy that ate the oysters, right?
He was that the oysters that we and my resident figured out which restaurant he ate at.
That's cool.
Yeah. Rod Street, can you read this one?
And had been bitten on the calf by a neighbor 5 days before. He had not sought medical care immediately. The injury on examination was profoundly unwell. His temperature was 35.2. His blood pressure was 72/42. His heart rate was 142 beats per minute, and the GCS was 14/15. There were multiple perforate lesions over his torso and limbs. The bite injury was scab but clean, with no pus or erythema. What is the most likely causative organism? The dog and everything involved capnocytosis.
Yeah. What about those other ones? Could they cause an infection after a bite?
Different.
So what makes it capnocytosis here? Yeah, the purpuric lesions, the shock picture. Yeah, the dog. Yeah. And it's usually with underlying liver disease. The description can actually, in a board's question, sound similar to Vibrio, if you, especially without pictures. So it's really that exposure history. Capnocytophaga has a clear association with asplenia. So keep that in mind. Those are the patients who tend to get very sick. Another bite question. I think we're back to you.
A patient presented to the emergency department with a painful left hand after being bitten by a cat. He had a deep puncture wound with some purulent drainage and surrounding cellulitis. Wound cultures were taken and he was given broad spectrum antibiotics and tetanus vaccination. What bacterium is the most likely cause of this infection? This will be Pasteurella.
And why do you say Pasteurella for this one?
Because it's a bite, not a scratch.
Okay. And the animal?
Cat. Although dogs also have it.
They do. Yeah. We had basically this exact patient come in this weekend, except the right hand. He had a cat bit him, a stray cat. He was cooking meat outside and they were trying to steal the steak from the grill. And then in his hand within like 12 hours, like just blew up to be huge. And he had like erythema extending up the arm. But he actually didn't have deep infection or tendon involvement, and he is doing fine on antibiotics. But these come in all the time. Animal bites. So the key things to think about is we have these classical associations of what bacterias are associated with each animal, but it can be anything that's in the animal's mouth or on the person's skin who gets bitten, right? So it can also be staph and strep. Just for these questions, I'm highlighting some of the more unique ones. And how severe it is really depends on where it bite wounds. You worry about hands, faces. You worry about cat bites because those deep puncture wounds tend to go deep and can involve the tendons. But most animal bites actually come from dogs and rarely get infected. Cat bites much more often get infected. Whenever you have a bite wound, you know, you want to think about, are they up to date on Tdap? Do they need rabies vaccine, depending on the animal, things like that. You never want to like close a wound. You usually leave them open. I think you guys know all of that. Because of the risk of infection, especially with like cat bites, people will give prophylaxis with Augmentin for 3 to 5 days, a short course. If you do develop a true infection, then the course is usually a bit longer. And amoxiclav is really just great at covering all of these bugs that we tend to see. The one thing we worry about sometimes, depending on the type of bite wound or if it's like a human bite or something, is it wouldn't cover MRSA, right? And sometimes we do see that be the cause of infection. So animal bite associations. So cats, dog, sharks. We'll come back to it. It's in the book. Alligators.
Pheromonas.
Yeah, alligators comes up. We get people with alligator bites, and like we had an alligator trainer at TGH the other year who like had, you know, he was feeding the one bit off his arm, so this came up. They also use leeches when they tried to reattach, which also are aeromonas, right? We talked about that one. Iguanas. Rat bite. This isn't really a skin soft tissue infection, but so rat bite fever. What's that one?
Or the other one that's in which is
Oh yeah, there you go. Good board review. Someone went to board review. Okay. And then macaque, again, not a skin soft tissue infection necessarily.
tuberculosis.
Stephen's got HSV.
The monkeys. Herpes B, right? Yeah. And then human bites. What bug do we think of? Picanella. There you go.
Oh, yeah, that makes sense. Sharks and Vibrio. That actually makes sense.
Oh yeah, it's Vibrio for sharks. Serratia with iguanas, but salmonella is with most of those small, like turtles, all of them, not necessarily bites, just those small creatures. You can.
Yeah. What? Do you know iguanas are the only one of their own genus? Iguana.
Good to know. You can look up the kimono dragon and get back to us. Yeah. So these are all associations out there from either board review or this book. Had fun facts. Okay, we're getting towards the end of this lecture. Just jumped right into this one. This is a change of topic. Cutaneous anthrax. So another skin infection that, you know, sort of fits in its own category in my mind. But it starts with a pruritic papule. It develops into a vesicular bullae. It ulcerates and then causes that painless black eschar. This picture is really also highlighting the amount of edema that can be associated with that eschar. And it's usually shortly after exposure from direct contact with an infected animal or contaminated animal products. You may see it on like hands. And it's a course of Cipro or Doxy.
Can I just add to that?
Yeah.
Sorry. I know you're going to probably talk about the drugs. So there's some cases, outbreaks of animal hide drugs, just for those who haven't seen that. It's a drumming circle. Also, black tar heroin vagrants, don't know if that one should be more being imported, but that also has anthrax because it's spores from the environment.
So was that drum question from ITE?
Yeah, the kangaroo drum question that we had last year. Cutaneous anthrax or what?
That's still.
I know. We'll never forget that.
That is living rest in my head.
I know there's drum, but was it kangaroo hide?
I think it was, yeah. Wasn't it?
That I didn't. Yeah, that would throw me just by geographic.
Kangaroo hide drum. Like he's cured for you with crystals. She did her own gardening.
Yeah.
That should import it.
That was
Yes, that is a good one. Yep. Yep.
No, what's your name?
Okay. Abdullah, can you read this?
63 years old, crab fisherman, developed a painful lesion on his left ring finger. He first noticed throbbing at the tip of his finger, following which a slowly enlarging lesion developed. There was some stiffness in the index finger, but he had not noticed any swelling. He had not experienced any fevers or rigors. He felt as if the pain he was experiencing was disproportionately greater than the lesion seemed to warrant. On examination, his temperature was 36.8. There was a violet colored lesion on his left index finger of 4 centimeters in diameter. The hand had a raised border with central clearing. There was no swelling associated with the lesion, and there was no tracking lymphangitis.
What's this one? Why do you think that one?
Well, there was no tracking lymphangitis.
And you would expect that.
HSV type pattern, and anthrax is actually exposed to the crabs.
Marina wouldn't hurt as much as it hurts. And HSV would be like with them, which is not what they're saying.
You guys got the right answer. There's Cephalothrax. Direct contact with animal or animal product. So it's often occupational exposures. Butchers, fishermen, farmers, veterinarians. It's a quick incubation period of 1 to 2 days compared to some of these other things. And like you guys were saying, erysipelothrax can cause more of a lymphangitic picture spreading. This case did not. And then they talked about other things you could worry about, like the water exposure could make you think of Mycobacterium marinum, but it wouldn't be as quick onset. This is a picture of this infection, cellulitis, and then these painful lesions with lymphangitis. So over time, you would expect to develop those. And then the management is usually penicillins or Keflex or IV antibiotics if it's severe. We have another one in the similar category of infections.
Which of the most appropriate treatment? A 37-year-old woman presented with rash on her finger. It had been present for 2 months and had not improved. There was no history of fevers, and the rash is not painful or draining. She has medical history of type 2 diabetes, lives in Chicago, has not traveled in recent years. She was a carpenter and recalled pulling a wooden splinter out of that finger 1 month before the rash developed. She lived with her partner and 8-year-old son, who were both well. They had a pet dog and cat that were healthy and owned several exotic fish. This patient sometimes helped her son clean the tank. On examination, there was an erythematous lesion that was non-tender, warm, or fluctuant. There were no other skin lesions present. Investigations, plain radiograph showed no fracture or foreign body.
What do you guys think this is? Which one?
Off me there. And we're
What if she started to have spreading lesions up the arm? Does she have an exposure for that one?
wooden splinter.
Wooden splinter, yeah. Yeah, that's what they're trying to point you to. Oops, sorry, I forgot to ask you guys which one would treat that, but I hope you know out of those categories. So yeah, and they're saying this is a fixed cutaneous form, as there's no typical lymphangitic pattern, but and she has other risk factors here in this history, but it was really the wooden splinter that would point you towards sporotrichosis. I don't know that this is a perfect question. You can have, if you do have that nodular lymphangitis, it can also be things like staph and strep, but that you would expect to be a pretty acute onset. And sporotrichosis, you usually have to treat. This picture is a little better at showing you the spread of lesions up the arm, and the indolent nature is pretty quick. we had someone come in with something that looked very similar to this last month, and with the nodular lymphangitis, but it had developed over a few days. Our medical student was great. She wanted to treat with itraconazole, and we said it seems like a little too fast. We found a different cause, but yeah, it's inoculation. So we often learn about the rose thorn, but it can be anything in the environment that's sort of contaminated with soil. So those sporotrichoid lesions or nodular lymphangitis, it's now like our fourth question about one of these. It is something I feel like, it's sort of a unique group of organisms, and they're very different. The case we had was a Nocardia brasilensis that was causing that nodular lymphangitis. It was cool. And that one is also associated with similar risk factors as sporotrix. Our patient was like someone who did a lot of odd jobs outside, cleaning gutters and stuff. So at some point probably poked the finger where it was, and then it started in the finger and then spread. But it was, again, within a few days, it had developed very quickly, as opposed to sporotrichosis, you'd think would be a bit slower. And then the other ones are up there. So this is the last question, and then the last couple slides.
Male, fever, poor appetite, and malaise for several days. He had multiple painful areas of erythema with skin peeling on his chest, axilla, lower back, buttocks. Several intact flaccid blisters were also noted containing yellow fluid. Patient had not taken any meds recently and had no drug allergies, which the following statements is true about this toxin-mediated disease. It's not B.
Oh, it's staphylococcal scalded skin syndrome.
Strep also from this. But I think kids are more likely to die.
What's your guess?
The B sound.
I know, a couple of these sound very fast.
You're gonna call it.
Makes sense.
And,
Okay.
Okay.
I mean, these sound right.
So you guys knew it was a toxin-mediated infection, right? And you got the correct syndrome, staph scalded skin syndrome. But it's exfoliative toxin A or B. TSST and enterotoxins are toxic shock syndrome. Yeah, and you were right. Whoever said it's not B, because B was like the bullae will not, be broken. They do have a positive Nikolsky sign in this. They rupture easily. And then the part C, the mucous membranes, was getting at the key feature. Like often you're distinguishing this from something like Stevens-Johnson or 10, and in those cases you would have mucosal involvement. You do not here. D is, I feel like that's sort of a cheap answer for it to be the correct one, because it's not so much infectious. But yeah, if you have a lot of skin involvement, it's like a burn patient, right? They're at risk for fluid loss, dehydration. Mortality is actually a lot higher in adults than children. Fun fact. And we highlighted a lot of these already, but it starts with like that scarlatiniform rash, and then you develop those flaccid bullae that rupture, and then the exfoliation. And we talked about the management. Toxic shock syndrome, antigen-mediated, TSST1, and enterotoxins. So you start with sort of a febrile illness that's not specific, and then you get very sick and diffuse erythroderma. Risk factors: foreign body, nasal syndrome, highly absorbent tampon. We actually had a patient like this after she had a C-section with retained products of conception. She developed that sunburn-like rash, and Cilia was very aggressive in getting OB to go back in and do further surgical intervention, and then she got better. She was in shock for a while. The strep toxic shock?
No.
Scalded skin. It's usually a different looking rash, those bullae and that scarlatiniform rash. I mean, you're going to treat them pretty similarly in terms of antibiotics. And then the picture B just shows what it looks like when this one desquamates. It's more of like the skin peels. It's not like with the scalded skin where you have the deeper skin layers lost. And then strep toxic shock you can get, as you guys were saying, toxic shock from staph or strep. This is more variable. The rash is less pronounced. More often people will be bacteremic from this. Yeah. And you usually have a risk factor, often recent surgery or traumatic injury or viral infection. And that's all.